Hi, my name is Alyssa Auvinen, and I manage the fruit and vegetable incentives work at Washington State Department of Health. And today I'll talk about a specific food as medicine intervention called fruit and vegetable prescriptions. I'll provide a brief overview of what fruit and vegetable prescriptions are, give an example of how they have been operationalized in Washington State, and also some of the challenges and lessons learned that we've learned over the last few years, and then end with some high-level opportunities for sustaining fruit and vegetable prescriptions. So what are fruit and vegetable prescriptions? Well, they're one promising food as medicine approach to healthcare and one that equips low-income patients with financial resources to purchase healthy food. Fruit and vegetable prescriptions are a pretty simple concept and health intervention, with the caveat that there are many ways to operate a program. Eligible patients are typically those who have a health risk or diet-related diagnosis, lack access to nutritious foods, and are referred to or enrolled into a program by a healthcare provider or health insurance plan. These prescriptions, which are often paper vouchers or debit cards, are fulfilled through food retail outlets and enable patients to buy produce with no added fats, sugars, or salt. Often these prescriptions are accompanied with regular health or nutrition education and goal setting for the patient. And ideally, fruit and vegetable prescription programs are or will be designed to improve healthcare outcomes, optimize medical spend, and increase consumer engagement and satisfaction with their healthcare. More and more fruit and vegetable prescriptions have been cropping up throughout the country, in part fueled by the 2018 Farm Bill that includes specific funding for the USDA to administer a produce prescription grant program. Research on these types of prescriptions is emerging, and programs have been associated with improved food security among households with children, improved glycemic control among adults with type 2 diabetes, and increased fruit and vegetable consumption among hypertensive adults, just to name a few outcomes. One particularly enticing study from 2019 modeled a fruit and vegetable subsidy for Medicaid and Medicare beneficiaries and found that this would lead to significant health improvements and be highly cost effective for the US. The modeling showed almost 2 million cardiovascular events could be prevented and nearly $40 billion saved in formal healthcare costs over a lifetime. So I'm going to pivot a bit and explain how the fruit and vegetable prescription program that we manage at the Department of Health works. For some context, we piloted this program from 2016 to 2019 with funding support from a USDA Food Insecurity Nutrition Incentives, or FINI grant. And in 2019, the Washington State Legislature appropriated our department with state funds to keep this program running, along with a few other nutrition incentive programs. Right now, we're working with 12 healthcare and public health organizations across the state. And in 2020, we served about 2,000 people through the program. So providers screen their patients for food insecurity and having or being at risk for a chronic condition like having diabetes, prediabetes, or hypertension. And they enroll eligible patients into the program by filling out a questionnaire, collecting basic information about fruit and vegetable consumption and health. And providers, of course, distribute the prescriptions, which are $10 cash vouchers good toward the purchase of fruits and vegetables. Patients receive the equivalent of $10 per week or $250 worth of vouchers over a 6-month period, or double that if they live in a household of 6 or more. These vouchers can be redeemed at any of 170 Safeway stores in Washington State. So over the course of the last 4 years, we've experienced some challenges. So I just want to focus on lessons learned that I think others may find useful. First is allowing some flexibility for healthcare partners has been very important. We allow some flexibility with program implementation in that the individual healthcare organizations get to decide what patient population they want to prioritize for this program. So for example, if they're wanting to target patients who have prediabetes, diabetes, or maybe cardiovascular disease with the prescriptions. Also, because of COVID, our healthcare partners turned mostly to remote services last year, so had to mail the vouchers to their patients rather than distribute them during monthly in-person meetings. And allowing the healthcare partners to do this was critical to keep the program running last year. Next, evaluation and reporting requirements may always be a lesson to learn. Especially last year, we know that there were so many competing priorities for our healthcare partners, and taking time to enroll patients and collect data for the program is time consuming. So making sure the healthcare partners have a vested interest in program evaluation is important. And lastly, I want to mention the importance of having patient voices and feedback about the program. One of the ways we incorporated this was through a photo voice project, so gathering program participants and using a community-based participatory approach to evaluate the program from a qualitative lens to essentially understand what's working and what's not for patients. One of the things that became apparent through the Photo Voice project was that patients wanted to improve the redemption process for these benefits. So we've been exploring how the prescriptions can be integrated onto a card or an app in the future. I want to briefly touch on sustainability of our fruit and vegetable prescription program and other programs around the country. Frankly, we know that grant funding or state funding for these programs is not a long-term solution. Because food insecurity is a social determinant of health and can be a driver of patient outcomes, and we also know that diet-related chronic diseases drive up healthcare costs, I think the big goal for these types of programs should be for health insurers to incorporate these types of programs into their payment structures. Organizations around the country like DC Greens, Eat SF, and Reinvestment Partners are doing a lot when it comes to engaging health insurers in these funding conversations. And I think there is an exciting movement for insurers to be key players and partners in finding sustainable solutions to fund food as medicine programs like this. And so I want to end on what I see as some opportunities for states and Medicaid managed care organizations to help systematically engage and fund interventions like fruit and vegetable prescriptions. This is not a comprehensive list, and I'm keeping the opportunities to just a few for states and MCOs. At a state level, there are opportunities for sustained funding and significant evaluation. For example, states could fund pilot projects to evaluate the impact of produce prescriptions for Medicaid beneficiaries. An example is that California has dedicated $6 million in state funds to pilot the provision of medically tailored meals in its Medicaid program. And while produce prescriptions are not medically tailored meals, there is kind of a precedent for funding nutrition intervention pilots in this way. Additionally, states can use Section 1115 demonstration waivers to evaluate the impact of produce prescriptions for Medicaid beneficiaries. Two examples here are in North Carolina with their Healthy Opportunities pilot. They will be funding and evaluating the impact of produce prescriptions. And I believe Massachusetts is also doing this through their 1115 flexible services program, in which they pay for health-related nutrition and housing supports for certain Medicaid members. Medicaid managed care organizations can provide coverage for produce prescriptions as value-added services for certain members. In Washington, we are just beginning to work with an MCO on planning a produce prescription pilot for their members. We'll use the model we currently have in place and really just work to figure out how to target the benefit to their members through the clinics that we currently work with, and look at some key indicators that hopefully help make the case for sustained investment for that MCO. So that wraps up my presentation on fruit and vegetable prescriptions. I look forward to our panel discussion and questions.